So hello, everyone. Uh, my name is Gustavo Medeiros. I'm a recently hired faculty member here in our university. Very happy to be here at the University of Maryland. Um, we are working in the Depression Center, which started operating this month. And as part of our one of our goals is to bring experts to visit the university and to give talks. Um, the most here in the grand rounds, we really ask them to try to make clinically relevant talks so we can all benefit from it. Today we have Dr. Sanjay Matthew. We have been following him for a long time, and we are very happy that he accepted our invitation. So very renowned researcher in the area of treatment-resistant mood and anxiety disorders, also some important work in PTSD. So he's originally from Houston. He graduated from Baylor, then spent some time in New York. He did his residency at Columbia University. He did his postdoc in mood and anxiety disorders also at Columbia University. Then he spent some time at Mount Sinai, where he co-directed the mood and anxiety program there. And then in 2010, he went back to his hometown, Houston, and he has been really flourishing in at Baylor. So he's a full professor there. He also has several other positions. He's the vice chair for research. He's director of the Mood and Anxiety Disorders Program. He also works in the VA as a staff physician, and he's the senior scientist at the Menninger Clinic. Um, and his research has been very well funded. He has been funded by NIH, the VA, PCORI, industry, and has published 180 manuscripts and book chapters. So most of his research is focused on experimental therapeutics, so development of new pharmacological treatments for TRD, anxiety, and PTSD, and also better understand the physiopathology to try to find biomarkers of response to these treatments. So thank you so much.
Thank you. Thank you, Gustavo, for that very warm welcome and also for hosting the opportunity to see your clinic and your program. And so it's very exciting that there's this new depression center for your department and for the university and for the people, most importantly, for the patients of Baltimore. I know you treat underserved patients who often have limited access to the cutting edge novel therapeutics. And so for any number of reasons. So it's great to try to bring some of these interventions to the patients who are most in need. So I'll be talking about ketamine treatment-resistant depression, and just give a snapshot of what I think are some of the major challenges in the field, but also some of the opportunities for progress in both clinical care and research. Not advancing. Click here.
That now will work.
Okay. My disclosures and include grant funding, NIH and PCORI. And then the objectives are to review really quickly, because I want to get more into sort of future directions. And many of you are familiar with the story of ketamine, S-ketamine, but also review what are the risks and liabilities. And then what I view as the single biggest challenge is how do you actually make this a feasible treatment? And ultimately, what is the value of a rapid acting antidepressant if there's no durability? And so that's something the field has been grappling with as we also talk about psychedelics and psilocybin. What is the durability and what can we do to extend the transient benefit? Then some words about clinical, biological moderators, predictors of response. And then finally, how do these newer treatments compare to the gold standard of ECT? And then some recent data on comparative effectiveness, specifically with ECT. So just a reminder, what do we have for difficult to treat depression? Besides ECT, of course, RTMS, multiple forms of RTMS, multiple machines, multiple ways of administrating, vagus nerve stimulation, which FDA approved, but unfortunately not covered by Medicare. Hopefully that will change with the new study that's underway and should be completed in the spring. So we'll finally see if VNS is better than sham VNS at a prolonged endpoint. And if that's positive, then our patients will actually have access to that treatment. Combination of olanzapine fluoxetine combination, and then several atypical antipsychotics also have an indication for adjunctive treatment. And then adjunctive esketamine nasal spray received the treatment-resistant indication in 2019, received a subsequent indication in 2020 for patients at acute suicidal risk who have MDD. So one of the issues with drug development in psychiatry, but across the board in medicine, is it takes many years, up to $1 billion, preclinical, multiple stages of testing. So hence the attraction of repurposing already known molecules such as ketamine, which of course was used since 1970 as an anesthetic agent. And it's been awfully difficult to develop new targets in depression, and it's not for want of trying. This is just a schematic of multiple abandoned programs and their mechanisms of action since 2006. We've been involved in many of these failures. Most of the work I've done has actually been in failed programs where you spend many years and then you have exaggerated placebo responses that kill nice ideas like corticotropin releasing factor antagonists, substance P antagonists, et cetera. And the list goes on. There's, since 2007, multiple other compounds that work in the glutamate system, either as so-called low trapping antagonists or glycine modulating type drugs, all have failed for a number of reasons. But there's been a lot of interest in developing drugs that interrogate the glutamate system, multiple targets, including NMDA receptors, which we'll talk about extensively with the ketamine story, but also drugs that implicate AMPA receptors, potentiate AMPA's activity, and its enhancement of brain-derived neurotrophic factor and other downstream mechanisms that ultimately work on enhancing synaptic plasticity. Let me just go back there. And so multiple glutamate-based compounds have entered clinical trials. Some are very late stage testing. Ketamine, its initial mechanism of action is as binds to the PCP site within a inotropic channel pore, and membrane depolarization believes a magnesium block with co-agonist binding, and calcium and sodium enters the cell. Now, that's sort of the simplified view. A much more complex view, and this is one of many wonderful review papers looking at the disinhibition of glutamate release as a potential mechanism for ketamine. So ketamine is binding to NMDA receptors and GABAergic interneurons, which leads to hyperpolarization, decreases in GABA release, which then causes a release of glutamate, which then downstream enacts plasticity enhancing mechanisms, including the TrkB receptor for BDNF and upregulation of mammalian target of rapamycin, or so-called mTORC, which is a pathway implicated in neuroplasticity and enhancement of AMPA receptor potentiation and activity. Now, interestingly, psychedelics may also have final common pathways that also implicate many of these systems, although the initial target is very different, the serotonin 2A receptor. But the ketamine story is much more complicated than a simple disinhibition hypothesis or glutamate release, because there's some suggestion that ketamine certainly works perhaps via opioid mechanisms. Studies have shown that giving naltrexone prior to ketamine infusion can reverse some of the expected antidepressant effects. A lot of work done by Todd Gould's lab has really focused on an active metabolite called HNK, which you can see here and here, which works through a variety of mechanisms that are independent of NMDA receptor activity. So stay tuned. Todd's lab, of course, is at the forefront of this, trying to figure out how does ketamine actually work. And I'll just make the point with this slide is that not all NMDA receptor antagonists are antidepressant. And this is just a partial list of many of the failures clinically over the last 5 to 10 years, including phase 3 clinical trials of something D-methadone, the D isomer of methadone turns out to be NMDA antagonist properties. There's subtype selective actions, but there was 2 negative phase 3 trials. Subtype selective subunits have failed, partially agonistic glycine site, and so on. And so just because you have NMDA receptor activity does not mean you have antidepressant efficacy. And yet this is the most recent failure, subtype selective NR2B antagonist in depression. So I'll quickly go through some of the historical data. The first well-known study was the Carlos Zarate NIMH program study looking at a sub-anesthetic dose of ketamine, 0.5 milligrams per kilogram over 40 minutes in a group of 17 patients at the NIMH Clinical Center. They're washed off of medications. These were patients with treatment resistance. And this was really a replication of the initial work published in 2000 by John Crystal, Rob Berman, Dennis Charney, showing that in 8 patients, there was a dramatically fast antidepressant effect. So Carlos's group replicated that finding, quick onset of activity, lasting for as long as a week, 70% response rates at about 24 hours. That was a within subject crossover design using saline as a control. So one of the challenges, of course, with saline is that there are challenges in blinding. When you, having a hard time with the pointer, but when you're giving saline, as you can see here, you're not really seeing a decrement in the antidepressant response when you do a with subjects crossover design. So we wanted to use an active control as a comparator. We chose to use midazolam or Versed, a commonly used benzodiazepine, to see if we could mimic at least some of the anxiolytic effects, some of the cognitive effects of ketamine, but without dissociation. So it turns out that the response rates were very similar. We had about a 2/3 response rates at day 1, lasted about a week, used the same paradigm for ketamine dosing. And this was in collaboration with James Murrow at Mount Sinai, but really showed that in a parallel arm design, we found essentially the same effects, giving us a little more perhaps credibility that ketamine was antidepressant above and beyond its anxiolytic and cognitive side effects. Now, a challenge for this, of course, is midazolam is not a perfect blind. There's minimal to no dissociation with midazolam. When you do a dissociation rating called the CADS, ketamine was 3 times higher average than midazolam. So midazolam, although you see more and more of these midazolam controlled studies, by no means is that a I would say credible control. It's still a challenge to come up with the credible control. Yes, Todd. Yeah, I mean, we've played around with a lot of different possibilities, including opiates, which still wouldn't have the dissociation, but would mimic some of the other. It's been suggested IV amphetamine. There's any number of possibilities, but now the field, when they're doing studies, essentially it's boiled down to saline or midazolam is commonly used. To use that as a control, we've not looked into that, but it could be. And it's interesting that the issue of control, the FDA, and we'll talk about the Spravato studies, the intranasal esketamine studies, the FDA recognized there's functional unblinding whenever you do a ketamine clinical trial. They did not require Janssen to do any kind of midazolam or active control arm. And so that remains a challenge in some of the interpretation, particularly for the relapse prevention randomized withdrawal design studies. So this was an NIMH-funded study looking at the different doses of ketamine and its acute antidepressant efficacy, as well as its impact on dissociation. And what was found is the 0.5 milligram per kilogram dose was actually the best dose. And going higher did not significantly add much benefit clinically. As you can see on the right, 1 milligram per kilogram has much higher dissociation, but did not perform much better. And so as a result, clinics generally start with this 0.5 milligrams per kilogram and then may titrate upwards if needed according to tolerability and benefit. There doesn't appear to be much of a benefit with the much lower doses, although some patients certainly are started on that for tolerability purposes. And there's been now a wealth of data supporting its efficacy in suicidal ideation. There is that indication for esketamine nasal spray for suicidal patients. Even there's a suggestion, even independent of its antidepressant efficacy. So patients had reductions in some of the suicide items, even when you control for reductions in the overall MADRS. So ketamine, the way we're using it is a racemic compound. The S-ketamine is the S isomer, and that's been used in Europe for a number of years as an anesthetic. The S isomer was never approved here as an anesthetic agent. But there's also the R isomer, which is another area that Dr. Gould's lab has been very interested in. And there's preclinical suggestions that R isomer may actually be associated with less psychotomimetic side effects, less abuse liability, while retaining antidepressant efficacy in animal models. And then you can see its metabolism to HNK and norketamine. So the FDA approval then was in 2019. This is for the nasal spray. Then we talked about the second indication. Practically, the administration can be a challenge in that there is a requirement for an FDA mandated REMS program. So this is not a take it home procedure. This is in the clinic under supervision for at least 2 hours for vital signs monitoring, monitoring for sedation, dissociation, et cetera, driving restrictions, which sometimes makes the practicalities challenging. In many of our patient populations, of course, are using public transportation. You can't just discharge them to a bus. The VA, we have funding to take patients home, but that often is a challenge. And so clinics that are bringing this on board have to really think through the logistics and the feasibility, much like we think through for ECT, but this is something that has to be considered. Now, how does the intranasal compare to the IV ketamine? The rationale here is you're going to have less of a Cmax for your established nasal esketamine doses, which are 84 milligrams and 56, compared to the standard 0.5 milligram per kilogram IV. And so having a sort of less concentration maximum. Presumably, there'd be less dissociation, less dose-related blood pressure elevations, and the dosing here is done independent of weight. So it's not a milligrams per kilogram dosing, and the bioavailability is about 50%. And this is what the nasal spray applicator looks like. It's patient self-administered, and the induction course is twice a week for 4 weeks. So you're getting 8 treatments. If you're a responder, you then go to once a week for weeks 5 to 8, and then the maintenance is every 2 weeks or once weekly. How far do you go? There's now data for more than 3 years in terms of long-term follow-up. So what clinics are doing is highly variable. Some clinics, if you've responded and done well, bringing in patients once a month. Others, depending on the durability, bringing them in more frequently, and so on. So there's a lot of variability and a lot of unknowns. What do you do beyond week 9 for the maintenance phase? And then the short-term data, one of the challenges in interpreting the short-term data, these were the phase 3 esketamine trials, is patients in the placebo arm were not just given a nasal spray to self-administered, which was saline, they were given a newly administered antidepressant on top of that. So you look at the placebo response rates, they're 52%. I mean, that's a huge placebo response rate at 4 weeks. And the reason we're thinking is that this was an antidepressant plus the nasal spray. You can see the esketamine response rate difference of about 17 percentage points, and you see the remission rate differences. But overall, the drug placebo difference was about 4 points, which was statistically significant. One of the phase 3 studies was actually not statistically significant. This was the study done in elderly populations, while the other phase 3 study had about a 3.5-point difference. So these were not whopping effects compared to what you saw with some of these early Zerati studies in terms of drug placebo differences. The longer term studies, this is a relapse prevention study. So a patient is stabilized, open label on esketamine nasal spray, and then randomly assigned to continuing on it or placebo. And you can see the risk reduction of about 51% over the subsequent year, or 70% for those who achieved stable response. This is the longest study ever published with respect to ketamine or esketamine, more than 1,000 patients. This is open label follow-up. So median maintenance was up to 56 months. And you can see that if you responded in the induction phase, you generally maintained your gains over the subsequent period. Now, of course, the challenge in interpretation is this is only looking at patients who continued on. So there's a selection bias. This is open label information. But with those caveats, the maintenance remission rate was 46%. And if you stayed with it, there was a 4.5% dropout due to lack of efficacy. But in terms of when you're talking to patients, what is the long-term show? This is the best data and that we have at this point, albeit open label. And then this is from the package insert, the warnings and precautions and the abuse and misuse. And again, we're reminded that it is a Schedule III abusable substance. We all saw the Matthew Perry news last week from the coroner, and he was misusing, although he was going to a ketamine infusion clinic for treatment, he was also misusing and abusing ketamine, leading to what happened, unfortunately. And then you can see what are the absolute contraindications for esketamine as per the package insert. The bladder is interesting, the ulcerative and interstitial cystitis. So we know that ketamine abusers, particularly in countries where ketamine abuse is more common than in the US, such as Taiwan and some East Asian countries, high dose ketamine is associated with ulcerative cystitis, hemorrhagic cystitis, so-called ketamine bladder. And so throughout the Janssen studies, there was surveillance longer term for any changes in urination, bladder, urological type complaints. And so that's something certainly we look for. There was not an enhanced signal for cystitis in these longer term studies, but I mean, given the fact that that is well described as a direct toxicity to the bladder, that's something that we're aware about and we talk to our patients about. So what are the major challenges in the field? And I alluded to the transient effect. And what can we do clinically to enhance or prolong the period of wellness? And looking at enhancing neuroplasticity and how can you leverage enduring learning mechanisms which are presumably taking place. Well, one thing that's been tested, can you simply give an oral medication after a ketamine course to prolong and extend the well period? And so we looked at riluzole, as did Carlos Zarate. Riluzole is a glutamate release inhibitor, FDA approved in ALS, Lou Gehrig's disease. It has decreased excitotoxic activity, enhances neurotrophic factor expression, and so on. Unfortunately, all of those studies were negative, did not beat placebo in preventing relapse. Lithium was also studied by James Murrow and did not find a beneficial effect. D-cycloserine, which is an antibiotic, but at high doses functions as an NMDA antagonist, also was not beneficial in prolonging ketamine's effect. Psychotherapy would be a reasonable adjunct, and the group at Yale, led by Sam Wilkinson, looked at CBT versus treatment as usual for patients who responded to an acute course of ketamine and did find some benefit in patients following ketamine. And then there have been some mindfulness-based motivational enhancement type therapies that have also looked at that. So Rebecca Price at University of Pittsburgh has really developed a very inventive iPad-based program, which she was testing following the successful treatment of ketamine 24 hours after ketamine as a way to prolong and extend the benefit. And it's called Automated Self-Association Training, ASAT. So it's a twice daily computerized session, about 15 to 20 minutes per session, conducted over 4 consecutive days. So after the single infusion, it'd be 24-hour, 48, 72 hours, 96 hours, twice a day. And it's really looking at subliminal, supraliminal, verbal, and pictorial evaluative conditioning blocks. So a Pavlovian conditioning paradigm. And what was found was active ASAT was effective in bolstering implicit positive self-associations using something called the implicit association test, IAT. And this is from recent paper just showing that post ASAT, there was a strengthening of the associations of me and smile versus me and frown. So self-referential in bolstering these positive self-association. So it's a the stimulus pairings, positive traits, which are the unconditioned stimuli, using words and pictures. So these were words of sweet, attractive, pictures, photos of smiling actors, and then self-referential stimuli, which is the conditioned stimulus of the word I and then participant headshots. And there's a sham ASAT protocol, which used neutral or non-seferential conditioned stimuli. And what was found pretty remarkably, following a single infusion of ketamine, you can see in green, ketamine plus 4 days of ASAT administered prolonged the benefit of ketamine versus ketamine plus sham, which then had a quicker relapse after 10 days, or saline plus active ASAT. So active ASAT itself maintained saline's benefit, but was not profoundly antidepressant. So these were effects after just a single infusion. And then when you look out even up to 120 days, and this was recently published, that there was still some suggestion of benefit for the single infusion following the ASAT 4-day digital training. And what was the measure of target engagement was looking at this implicit association task, looking at implicit self-worth. And it's a computerized paradigm, which is pretty well validated. And what was found is that decreased implicit self-negative associations after ASAT predicted lasting benefit a month later. So as you can see on the MADRS, if you had low scores, that was associated with improvements in negative self-association. So implicit self-worth was enhanced, in other words, which led to these durable effects. So that's well and good, but in the real world, nobody just gives one ketamine infusion. So we're collaborating with Price to really look at this in the real world clinic setting, where can you administer ketamine after the first, so in the real world community clinics, you're getting 6 to 8 infusions during your induction phase. So can you give several bursts of ASAT, one following the first infusion, the second one would be after the induction phase, after the initial treatment period. So instead of having the patient then come in every week for maintenance or every 2 weeks, can you prolong and extend that? And then can you also do another burst during chronic maintenance therapy? So this is something you could do at home. It's done on an iPad, and it could be, hopefully the idea is to do a randomized trial of this versus sham in 600 patients as the next step. So we've been very interested in clinical biological moderators, predictors of response, as many people have been interested in this topic. And Dr. Price recently pulled data from numerous groups looking at this, patient level meta-analyses, what are the clinical moderators? And unfortunately, almost nothing came out positive, certainly nothing that you can hang your hat on clinically, looking at subtypes of depression, melancholic depression, family history of alcohol use, that's been suggested some other studies. But when you look at several hundred patients, there's nothing that strikingly comes out positive. So that leaves a big challenge for sort of trying to predict who's going to need 6 to 8 infusions or treatments in general. And this is work led by Brittany O'Brien in our group, finding that there are clear trajectories of response. There's some patients who are going to have this early, classic, rapid onset of action. Some patients, of course, will not get better at all in red or even get a little worse. And then some patients will be somewhere in between. So how can you sort of predict that from the get-go? And so we've been interested in using EEG in this context and examining the impact of ketamine on EEG parameters and using that as potential predictor of who will go on to do well. Essentially, EEG is trying to make sense of cortical microcircuits, and this is just a schematic looking at in the baseline non-stress condition where you have GABAergic parvalbumin-containing interneurons inhibiting pyramidal neuron expression, and that's sort of in the normal baseline state. With chronic stress, there is a dendritic atrophy, diminished function of somatostatin inhibition, and enhanced parvalbumin-containing interneuron inhibition of pyramidal glutamate output. So that's diminished output. Now, in the frequency bands in EEG, you can look at the high frequency band, the gamma oscillations, and gamma is thought to reflect increased excitatory drive to specific cortical regions, which trigger a rhythmic feedback inhibition from local fast spiking parvalbumin type interneurons. These high frequency oscillations have parallels to activity dependent plasticity. And as an example of that is long-term potentiation. And so several groups have been very interested in looking at gamma band potentiation as a potential biomarker for local microcircuit neuronal integrity as assessed via EEG. And so, and this fits in well with some of the hypotheses of how ketamine may be working by a disinhibition. So can you infer the degree of disinhibition through increases in gamma band activity? So we did a study looking at gamma power, frontal gamma power, as a function of getting a ketamine infusion. And what we found was in REM, this is work led by Nicholas Murphy, Marijn Leifheit. We found that during the infusion, there was a robust increase in gamma power, which then correlated to the durability of the benefit. So if the higher you had gamma potentiation, the longer and more robust your response was. So what we're now testing in a new study led by Nicholas Murphy and myself, we're testing this in a real clinic. So where patients are getting 8 infusions to try to figure out, can we predict who's going to go on to respond and not? And much of this work was adapted from Alison Nugent and colleagues, where they found an interesting interaction between your baseline gamma power and ketamine-induced gamma potentiation. So it's whether or not, so if you had low baseline gamma and high ketamine potentiation, clinically you did very well. That was the sweet spot for clinical response. While if you had different permutations of low, high at baseline and ketamine potentiation, you didn't do so well clinically. So this work was done with a single infusion in a highly experimental setting. We're now trying to bring this out to a infusion center in Texas called Lone Star Infusion, so named after our state. And it's a real world clinic, very busy clinic, and we're taking the EEG there. And that's the protocol. They'll get it at infusion 1, is infusion 4, as part of that experiment. And I will skip the work on neural complexity, EEG biomarkers, other to say that we're looking at all different types of ways of looking at EEG to predict outcomes, and there's different sort of biomarkers that are nonlinear. The gamma power is a linear model. So the final sort of unmet need or big challenge is, how does ketamine compare to our gold standard treatment? And of course, ECT for so many decades is the gold standard. You have a very busy ECT service here. So the first big study to really compare the two was done in Sweden, and it was published last year. These were patients referred for ECT. Most of them had actually had previous ECT. 15 to 20% actually had psychotic symptoms. So that's a very unique aspect of this trial. We've never enrolled patients with psychotic symptoms in any of our studies. But interestingly, these patients did not get worse, or there was no symptom exacerbation. They were randomized to the standard dose of ketamine over 40 minutes, and they were given up to 12 treatments. And then the ECT was right unilateral, 9% received bilateral. And what was the take-home point here is that the remission rates of ECT were superior, 63 to 46% remission rates for ECT versus IV ketamine, as you can see over the 12 treatment period. Response rate, 71 versus 57%. So a pretty sizable response rate advantage for ECT, with some caveats. So the overall sample was 63-46. You look at the age of 51 to 85, you break it down by age, ECT was far, far superior, 40% remission rate differences. But you look at the younger population, ketamine actually did better, 61 to 50% remission rate differences. So a real treatment by age interaction for remission. And I'll just mention, there are several meta-analyses of ECT versus ketamine published in 2022. Almost the entire meta-analyses was driven by the Swedish study. All the other studies had very small sample size, relatively poor quality. But the message up till about May of 2023 is ECT clearly has an edge, although the effect sizes aren't huge, and there could be even larger effects in the elderly population. So this is yet another meta-analysis showing the same basic idea. So then the ELECT-D study, this is led by Amit Anand, and we were one of 5 sites, along with Johns Hopkins was one of the 5 sites. This was primarily, in contrast to the Swedish study, primarily outpatients. So 89% of the patients were outpatients, 5 US centers. They had to have failed at least 2 antidepressants, 21 to 75 years of age. And so patients were referred to the ECT service. Now, why select from that group? If we took all comers, the fear was that patients would drop out if they got assigned to the ECT arm. It turned out that patients dropped out anyway. Post-randomization, pre-first treatment, we had many more dropouts for those assigned to ECT initially before they got the first treatment. But that was the rationale, to take the pool of patients who'd already been referred and had already been sort of positively inclined to the idea of ECT. So then they were treated for 9 treatments, 3 times a week for ECT, pretty standard, versus 6 treatments in this case for the ketamine arm. Primary efficacy endpoint was the self-report measure. Why a self-report measure for a clinical trial? PCORI mandated that. So this is the Patient-Centered Outcomes Research Initiative. They want patient-reported outcomes to be primary as part of their mandate. So this was a non-inferiority trial. So the hypothesis was the response rate is non-inferior with a margin of 10%. So ketamine is 90% as effective. And the a priori assumption was ECT response would be about 50%. So this is the consort. I know you can't read a lot of the details, but 93% completed 6 to 9 ECT treatments, and about the same percentage completed all 6 ketamine infusions. So a pretty good completion rate. These are the demographics. And a major limitation of all of the work in ECT and ketamine today are the lack of minority representation. And we were talking about this with Gustavo earlier, that, I mean, they're really, that makes it all the more important for clinics such as your own clinic to be able to recruit minority participants. Although this study took place in Baltimore, New Haven, Cleveland, Houston, some of the most diverse cities in the country, it was primarily a white population, as we tend to see in ECT samples. I mean, these are the patients who are being referred to ECT. So the quiz and MADRS was moderate, severe, baseline severity. So the primary outcome was quiz response, and you can see ketamine actually did better, or I can't say did better, it was non-inferior to ECT, 55% response rate versus 41% response rate. And you can see the secondary outcomes for CGI, MADRS, Montgomery-Åsberg were aligned with the primary outcome. When you look at the continuous measures, about a 2-point difference between improvement in ketamine versus improvement in the quiz. This is graphically what it shows from the paper. So a improvement of ketamine slightly better than ECT. Now, I think one of the most interesting parts of this study, which many people who just read the abstract may not really have appreciated this, because this was buried in the supplement of all the best stuff of papers, by the way, is always in the supplement. So always read the supplement. So at Baylor College of Medicine, where I'm located, we did the study in a VA facility, and our ECT response rate was more in line with what you'd expect. It was 61%. Ketamine actually did worse, 52%. Our site in Cleveland Clinic were the 2 highest enrolling sites, contributing 50% of the sample. But look at the ECT response rate in Cleveland, right? I mean, there's I mean, a massive disparity which is unexplained. I mean, why is ECT dramatically underperforming in a very high volume site, highly experienced site where ketamine did very well? So at the other sites, it was more even, generally favoring ketamine, with the exception of Hopkins, which had a slight ECT preference. So I mean, you could make all kinds of hypotheses. This was patient self-report. Different sites had different ways of administering the ambience of ketamine. Some places had very fancy ketamine rooms with muted lighting, shades, and a therapeutic environment. We were at the VA, where where may not have been the most comfortable seating and lighting and everything else. And there was hospital sort of alarms going off. I mean, much more chaotic milieu, if you will, all of which could influence a short-term 18-day outcome. So we really need to understand that. So in terms of cognitive differences, as expected with ECT, there were slight decrements, transient decrements in the Hopkins Verbal Learning Test compared to ketamine, which normalized by day 30. So otherwise comparable. What's alarming though, and I think if there's one take-home message from this talk, is we need to focus on our 6-month outcomes, because no matter how well you did, 56% of ECT folks are relapsing at month 6. Now, I should say after the study, it was treatment as usual. They could get maintenance ECT, they could get maintenance whatever, same with ketamine. But I mean, many patients, despite doing well, will relapse. And so we wrote an editorial commentary about what are the implications of this study for clinical practice. And appropriate non-psychotic patients with TRD should be considered for an induction trial. So when you're doing sort of risk-benefit assessments and you're talking to patients in a TRD clinic about the suite of options, TMS, ECT, ketamine, intranasal esketamine, down the road, psilocybin, presumably. Is this data enough to consider that? Perhaps. Now, of course, lack of insurance coverage limits the access. There are some major exceptions to that. Kaiser Permanente has started covering for its members ketamine, IV ketamine particularly. Connecticut, Yale New Haven covers it as a benefit. So could a clinic use data like this to lobby to their insurance for coverage? Certainly people have started to do that. But what we need are the long-term strategies, and that could be pharmacotherapy, it could be computerized digital interventions like ASAT, any number, but you have to sort of look at that at day one in terms of feasibility and what's the long-term approach. And so while there's been a lot of noise about rapid antidepressants, with Alan Schatzberg, we recently sort of called into question on the heels of some of the data from zuranolone as a rapid-acting antidepressant, the so what question. So if you're getting a patient better at day 3, and it's marginally persistent day 14, but not persistent at day 42, what's the big message there? Is it worth spending to the healthcare system $17,000 for a 14-day trial of zuranolone in that context without real evidence of durability? So how important is rapid response really in a chronic or recurrent depressive disorder? That's why in some ways I'm very hopeful that VNS will get approved, where the focus on VNS is not on the rapid response within a week. It's looking at 1-2 year outcomes. And we're all familiar with the term poop out. For SSRIs, we poop out. So my former mentor at Columbia was Harold Sackheim, sort of a neuromodulation expert. He used to refer to VNS as pooping in, because it doesn't work fast, but if you do well with it, there's a durability of outcome. So the challenge is we need to study suicidal patients, minority patients. We need to look at sort of strategies to maintain wellness. We need to compare IV versus intranasal spray. And that PCORI is actually funding that study right now. It just got a notice of award. So that's a hugely important study. And then how does this fit in with the psychedelic space? And so the follow-up to the ELECT-D study has just started looking at the same comparison, but in suicidal inpatients. So we'll have that answer in 6 years. So the summary points are the major challenges are how to prolong and extend. Where do we use this in the MDD treatment algorithms? The PCORI study suggested non-inferiority, although the long-term strategies are not well defined, and mechanism, it's an evolving complex story. NMDA antagonism is clearly the tip of the iceberg, as many modulators have failed as antidepressants. And I'll just end on this slide and then get to questions. I mean, it's a rapidly moving area, and there have been even professional societies that have cropped up in the last few years. This is one that is, I think, a particularly good one where they look at the evidence. They're not promoting things that are beyond the scope of the science and the clinical trials. And then if people are really interested in ketamine, there's a journal club sponsored by Oxford University, where they'll go through papers that are notable, and it's run by academicians at Oxford. So I will end with that and have some questions. Thank you.
Thank you, Dr. Matthew. I just had a quick question. When you were talking about your data with the ECT versus the ketamine infusions and the differences in sites, did you notice that there was a difference in, I know the mean age was around the 50s, but did you notice that maybe at some sites the VA tended to have an older population compared to some of the other sites?
That's an interesting question. We did a extensive, so looking across all the sites, we did not find age to be an important variable in those analyses. Now, age by site interaction, we did not find that either.
Thanks for the.
Thank you.
I also have a question about ketamine and evidence, or even if it's anecdotal evidence, of how effective either treatment is in individuals failed ketamine, effective or not?
Yeah, in this study, we didn't have enough data to do a really good analysis on that. The proportion of patients who had, patients who had failed a course of ECT were excluded from the randomization. So it was a sample who had either responded well in the past and relapsed, or were treatment naive to ECT. Now, on a large scale, there are some smaller reports that have looked at sort of ECT or ketamine and ECT failures, but those are relatively small, and there hasn't been a definitive answer to that. I mean, that'd be a great study to do a randomization and then randomize to the other arm for the non-responders. Yeah. No, exactly.
So thank you for the talk. Amazing. We are interested also in EEG, especially focused on esketamine, based largely on the work that you have done and other people too. And one of the critics that we receive is this is something that, so the increase in gamma, you will need to give the medication. It's not a pre-treatment variable. So you will need to have a esketamine trial or a ketamine trial. And then if they don't have the increasing gamma, maybe we'll need a second trial that you will have a higher dose, or to see if they have a further increase or appropriate increase. And then at that point, they will see the clinical efficacy already. And then the EEG will not be so clinically useful. How would you answer that?
Yeah, that's a fair question. What added value does EEG add if you're not able to use it sort of on day one as a predictor of how whether or not you're going to need 7 additional treatments? That's where we focused on the first infusion, sort of getting that information at infusion 1 to be able to look at the ketamine-induced gamma band potentiation, and then being able to sort of, if there is potentiation, how is that ultimately going to predict? It may turn out not to be predictive. So I don't think it's ready in any way right now to sort of use it in the clinical setting until we get more information. First of all, also about the reliability of that metric. The reason we're doing an additional EEG at infusion 4 at the midpoint is to get some sense of the stability of that measure. So say you are a massive gamma potentiator, the first infusion 4, how does that correspond? Is there some reliability of that metric, or is it all over the place as a function of having prior ketamine treatments, as a function of improved clinical state, as a function of variability in other factors? So I think the psychometrics of that marker have to be really well sorted out before you really throw it in the context of a Spravato clinic. But I think collecting the data is a sort of relatively non-invasive way to perhaps get some interesting, useful information.
We have a question in the chat that says or asks, how does psychoactive substance use, alcohol, cannabis, et cetera, interact with treatment response?
It's treatment response to ketamine if you're using sort of psychoactive agents.
Yes.
Yeah. We don't know enough about that because all of these studies exclude urine toxicology positivity, histories of abuse, usually in the last not only just 12 months, it could be for several years. So we do also know, though, that ketamine is studied in addiction populations as a way to decrease relapse in combination with mindfulness or relapse prevention strategies, work in cocaine use disorder, work from Columbia University, Elias Dakwar, and others. So we know that SUD populations can safely be administered ketamine and sometimes can lead to decreased craving.
Thank you very much. Wonderful talk. Question for you, maybe sort of, what do you think about this mechanistically? One thing I sort of struggle with is if you give someone a medication, ketamine or whatever, you're giving a dose and it's sort of, you have an effect. Neuromodulation is there's so many variables. Like it could be as simple as how you deliver your ECT, but even you think about things like VNS or DBS, and I think about like the closed loop neuromodulation. How do you see how do you know if you're doing the right neuromodulation? How do you see it as a challenge in the field given,
Yeah, like is neuronavigation guided TMS, is that the way to go? Do you have to sort of activate or interrogate specific circuits, a default mode circuit, any number of circuits at baseline, and then be precise in the targeting? That's the hope, right? And outside of specific platforms that do that, that's not what people are doing. I mean, they're obviously just treating a specific left dorsolateral prefrontal cortex at a specific frequency and hoping for the best. So unfortunately, yeah, the neuromodulation space, we have a long way to go for precision. And ECT, that will be very interesting with the latest data with magnetic seizure therapy, which was recently found to be non-inferior to ECT. With less cognitive side effects.
In IV ketamine versus ECT study, there are 8 people with OCD symptoms randomize it to ECT group, there is only one patient with OCD symptoms in ketamine group. Did anybody try to do the analysis excluding those patients, knowing OCD symptoms are much more difficult to treat either way?
Oh, with the OCD? Yeah, we have not looked at that. Yeah, the OCD is across the board, as you say. I mean, for ECT, and also the ketamine data with OCD is very mixed. There seems to be clear effects on the MADRS, but the Y-box reduction, some groups are finding significant reductions, others are not. Yeah, I mean, there weren't that many OCD patients. 8. Yeah. Yeah. Okay, we'll go. Okay, that's interesting. We'll go back and look at that specifically.
I was wondering, you said, well, you said you looked at mechanistically what may be happening like with your neurons, but what about experientially or psychologically? I'm curious if patients talk about how they understand this working or helping themselves. Is it like dissociating from their own problem? What do they understand?
Yeah, like the psychological mechanisms. I mean, and there's been a ton of work looking at ketamine-assisted psychotherapy, sort of in a similar manner to what you're doing with psilocybin guidance therapy, and sort of a reframing of your life and your problems, and sort of allowing the patient sort of to get outside their head and reframe fixed patterns of thinking. So there's entire sort of ketamine-assisted psychotherapy platforms that many clinics have adopted, exactly trying to capitalize on the dissociative experience and make sense of that. So instead of treating dissociation as a nuisance variable, right, it's something that some of these clinics are embracing as part of the experience to allow new forms of learning. Yeah, that's a very controversial area. Like, how necessary is that?
We need to stop here. Dr. Matthew has a flight to catch, right? So just when we were discussing who we would bring, we thought of Dr. Matthew because he's a extremely creative researcher. He's an active clinician, and he's a great speaker. So I think that we should think like what type of researchers we want to have. And I think that he's a great reference, at least for me. And thank you so much for coming again.